So one thing is
do you know if we're supposed to title this as anything other than just like
You can say
For what?
salary?
it's all.
I have no
idea.
I have no idea.
Down below, let's try the top 3 dots, because this is looking at. So once you open it there, use the top 3 dots, and it says present in this mode. The top 3 dots, present. Will that work? Okay.
Tie clip and all, huh?
Thank you. Trying to be fancy, fancy.
So now when would be the next time you wear a suit? Graduation? You gonna wear a graduation?
Oh, not a suit. I don't know. 'Cause I don't think I wear a suit for my white coat ceremony because I think
Right.
we'll see. Who knows? It only comes out during special occasions. But these are cedar goat colors.
You are not there yet. They still need to be a suit color.
This is what I wore to my interview.
Well, I can understand that,
Mhm.
you know.
And it kind of matches my presentation in a way.
If you have like a cedar girl, like, you know.
Oh, I don't have anything.
Anything on that?
It's just blue.
I'm just writing zeros.
Who are you?
I'm so excited. We thought you started. I was like, "Oh, yeah." Never mind, I don't know. I'm just being very grace. Who's your advisor? She's not. So I just told her how to cheat. I said, oh, she's been on TV for years. I said, I have 10 years, and it's coming back in 10 years to take my spot. She said, I appreciate that.
Good morning, everyone. I'm Brittany McConkey. I'm one of the professors here at SCU, and I'm super excited that you're all here today, so thank you so much for coming. We really appreciate your presence and your feedback for the students. And I'm going to introduce our first speaker, and this is Marley Smith. She's majoring in biology with a concentration in medical science. She's from South Africa and has been at SCU for 4 years. While at SCU, she was a part of the SCU women's golf team. After graduation, she plans to attend Ross University School of Medicine.
I'm Madeline, and today I'll be exploring one of the coolest intersections in science, neuroscience and elite athletic performance. Now, athletes are obsessed with training their bodies, but what if we've been ignoring the most important, powerful tool of all, our brain? During high-pressure situations, the brain gets flooded with excitatory neurons. This is where GABA will step in to modulate their inhibitory systems. So GABA does this by keeping movements sharp and precise and in focus as well. But here's the twist. We don't fully understand how training actually affects the brain. Does GABA adapt like a muscle does? That is the gap I'm trying to explore. Because maybe it's not just muscle memory, but neural efficiency that separates good from great. So for my hypothesis, I'll investigate how athletic training enhances GABAergic inhibition, improving performance under stress. Now, training sculpts the body, but what if it sculpts the neurochemistry as well, and we can actually measure it and enhance performance in athletes even better? So first of all, before we start, what is neurotransmitters? Neurotransmitters are chemical messengers that operate or travel through synapses. It is basically how these neurons communicate with one another. You get two types of neurotransmitters. You get excitatory neurotransmitters that are more associated with the go signals, intense activity. While on the other hand, we have inhibitory neurotransmitters such as GABA. They're more associated with slow down, keeping the brain cool and concise. Now, for athletes that has to focus under pressure, it is crucial to have a good balance between excitation and inhibition, because imbalances can be the difference between hitting the target or hitting the floor. Now, the neurotransmitter I'll be investigating is GABA. GABA, gamma-aminobutyric acid, is the primary inhibitor of the brain. It doesn't just calm the brain down, it actually refines it. So GABA dampens distractions, it sharpens motor skills, as well as preserving composure under pressure. But here is the fascinating part. GABA might be trainable. If so, elite athletes could enhance their network through intensive training. This means that they're not just physically fit, but neurochemically optimized to perform well under pressure. Now, during stressful situations such as hitting the last football goal or even hitting the last shot in golf, you can see here that neurotransmitters flood the brain. This can be helpful, but too much can cause overthinking, muscle stiffness, or just full-on choking. GABA then steps in to reduce neural noises, sharper motor control, as well as preserving composure under pressure. Now, it is very crucial to understand that there are no specific amount of GABA, but each different sport may have a specific amount that is specific to their sport. For example, precision-based athletes such as gymnasts will have higher baseline GABA levels for more precise movements. On the other hand, reactive-based sports will have lower baseline levels for more explosive muscle movements. Therefore, it's not about having more or less GABA, but the amount of GABA that fits the sporting demands of that specific sport. So the central question is, what separates athletes from the rest of us? Because sure, they train their bodies just as we do, but what goes on in their brain is actually the important one. When I refer to elite athletes, I'll be referring to athletes that do their job as a profession, or their sports as a profession. So what if training actually rewires the brain? And through training the inhibitory system, we can enhance the GABA networks even better. That leads me to that intensive training strengthens these GABAergic networks, leading to greater neural efficiency, better motor control, as well as better performance under pressure. So before I go into my specific aims, I wanted to show you the various tools I'll be using to measure brain activity, behavioral performance, as well as the chemistry of the brain. For specific aim 1, I'll evaluate how intensive training rewires the brain. This will be done in the motor cortex that is more associated with muscle movement and the prefrontal cortex that is more associated with precise movement. I hypothesize that elite athletes will show distinct functions of GABA profiles specific to their sporting demands. So the participants will conclude of 40 elite athletes that consist of 20 precision athletes and 20 reactive athletes. And the control group would be the non-athletes. They'll undergo pre-training where MRS would be used to measure baseline GABA levels and EEG will be used to measure the brain activity. They'll then go on for 6 to 8 weeks for training in the various sports, whereafter they'll come back and MRS and EEG will then be used to measure the brain activity again. As you can see here, I expect to see a decrease in motor cortex GABA levels and an increase in decision-making speed. But this will be only for reactive-based sports. Precision-based sports will show the exact opposite. Therefore, there is no specific amount of GABA that is crucial for every athlete. It's about having more or less, depending on the sporting demands. So my expected outcome, MRNS will show changes in GABA levels, where precision-based athletes will have a higher GABA baseline level, and reactive-based athletes will show higher levels of reactivation. fMRI will show better effective activation in the brain areas. Therefore, the brain can do more with less effort. For specific aim 2, I'll see how I can modulate GABA to boost performance in these athletes even better. I'll be using TMS, that is transcranial magnetic stimuli, that is a magnetic stimulus that stimulates the brain in a non-invasive way. This could lead to performance improvements such as faster reactive times, better motor precision, and as well as better focus under pressure. The athletes will be the same I used in specific aim 1. They'll also undergo pre-training where baseline GABA levels will be measured, but then they will receive theta burst stimulations. They'll have 4 sessions over a period of 2 weeks, whereafter they'll come back, MRS and behavioral tasks will then be assessed again. Here I expect to see that TMS will modulate the GABAergic activity in various ways. EEG and behavioral tasks will show better and clearer responses, therefore less effort, fewer errors. The important thing to note is that TMS will differ based on the sporting demands. With some sports that will need a more balanced TMS, while the others need a higher splurge. So why is this study important? If we understand GABA's role in performance, we can do more than just making athletes faster. We can actually rewire and transform their brain in a way that is perfect to their sport. This will also give us insight into more smarter sport training programs that is tailored to the athlete, neurotraining tools to enhance their focus and control, and even clinical applications. Because the same neural pathways that GABA uses to reduce stress in athletes could be used to care for anxiety, ADHD, as well as motor disorders. Therefore, it's not just about increasing the speed of athletes, but optimizing their brain-body composure better. For future studies, I would like to track GABA over longer periods of time. For example, through an entire season to see what effect this training could have on the inhibitory systems of the brain. Testing interventions such as neurofeedback or mindfulness could be used to measure and see if GABA levels can be trained, such as we train muscles in our body. I would also like to compare this over various different sports, such as team, individual, as well as mixed demand sports, with the ultimate goal of developing a neuroperformance toolkit that is optimized for the athlete and the sport they're in. So GABA might be the next unsung hero of elite performance. It is important to notice that the brain isn't just along for the ride, it is steering the ship. With optimized GABA levels, we can think faster, react better, as well as staying composed under pressure. Most of us think sports are mental, but my research shows it's neurochemical as well. And if this is possible, the secret to gold medals might not be buried in muscle, but in memory. So I would like to thank God, my family and friends for supporting me, as well as Dr. McConkie, Dr. Hudson, and Dr. Abram for all this support. Here's my references. Any questions?
sure you sent me the second, I got the first name, right, what were the two different names? And I got lost somewhere, sorry.
So the first aim, I want to see how training, the effect of training on the brain and the inhibitory system. And then on the second specific aim, I will use TMS to boost GABA stimulation.
Thank you.
Are there other neurotransmitters other than GABA that would play a role here as well?
Yes, glutamate, that is actually the excitatory neuron that will enhance levels for excitation.
What would you expect to happen if an athlete took excess GABA, like a pill form? How would that play a role?
Too much can cause can increase inhibition so much that that will become jittery, and too much shaky under pressure that can lead to depression.
You mentioned that this could improve care for anxiety and ADHD. How does that look like that?
I haven't actually researched in that yet. This is just what I want to read about. But I just know that the same pathways that GABA use can be used to measure that as well. So it has to have some similarities.
In your research, did you find any other example articles of this research done in mice or other animals that showed exactly how it would be measured? I guess the GABA would be measured, or comparing the ions.
No, so TMS will then actually be one of the first things that we want to do that for.
Other questions for Marley? Okay, great job.
While she's switching on screen, Mrs. Chappell. Chappell Cunningham. She's majoring in biology with a concentration in med sciences from Chattanooga, Tennessee, and has been at SEU for 4 years. She has been a part of SEU doing volleyball and softball, where she's awesome. I watched her play many times. And after graduation, she's going to take a gap year to work as a medical assistant before getting ready to go to PA school, which she'll get in the following fall. And we have more sports stuff. More sports.
Okay, so as Dr. Solori said, my name is Chappell Cunningham. I'm a dual sport athlete here for all 4 years. And I'll be presenting Capstone on real-time biofeedback as a preventative technique for shin splints. So you may be asking, what exactly are shin splints? Shin splints are a bone overuse injury. They're normally exercise-induced, and they find pain along the lower leg. This red area you can see here is where pain is typically found in athletes that are complaining of lower shin pain. This is a result of excessive force and pressure due to exercising too often and too much. When there's excessive force placed on the tibia, there is micro damages that occur within the bone. Specific cells called osteoclasts come in and remove damaged bone, and osteoblasts come in and repair this bone. The issue with this, though, is that when the rate of loading forces exceed the rate of bone reformation, inflammation occurs in the periosteum, which is the outer lining of the bone, causing inflammation and pain in the shin. So the significance of my study. According to a couple studies from the National Institute of Health, 60% of all lower limb injuries in running athletes are shin splints. Shin splints are the third most common overuse injury, following patella tendonitis and shoulder impingement. I know from personal experience, sitting out of your sport due to an injury that could have been prevented is not super fun. Mental health issues are at an all-time high in athletes right now, and getting injured only heightens the risk of this. Women are more likely to develop shin splints over men, and this is because of natural imbalances, hormone imbalances, wider pelvises, and also natural nutrient deficiencies like vitamin D and calcium. Both of these factors are very crucial in bone modeling and bone remodeling. And then the gap in knowledge that I'm going to be investigating is with wearable technology, which I'm going to talk about in a second. Delayed feedback is really the only thing that is accessible right now. So I'm going to be introducing real-time feedback as a technique of preventing injury. So some known causes of shin splints are excessive volume and overtraining, immense impact and force, incorrect foot striking pattern, poor footwear choices, repetitive stress-induced movements like running, jumping, dancing, and inadequate rest and recovery time. So as you can see, there are a multitude of causes of shin splints, making it a little bit difficult to completely prevent shin splints because you can't focus on all of these at one time. So a primary aim of my study is to find which one of these causes is the most important and how we can target that one to prevent shin splints the best. So some current therapies are, as I said earlier, rest is typically the most suggested therapy, but as an athlete, I know in the flow and the high demand of season, resting the suggested 2 to 4 weeks to decrease inflammation or even the 3 to 6 months to full heal is not super realistic or very feasible. So other technologies for therapy are implementing icing and regular stretching, utilizing some arch support orthotics, which kind of regulate muscle imbalance and prevent overpronation of the foot, which is internal rotation of the foot, prioritizing flexibility and specialized strength training, taking non-steroidal anti-inflammatory drugs on the regular to decrease pain and inflammation, and to perform cross-training exercises as a mode of recovery while still being in fitness for your sport. This could be cycling or swimming workouts instead of intense running. So this right here is an X-ray. The side on the left is the anterior to posterior view of an X-ray, and the one on the right is the lateral view. The thicker bone of these two is the tibia, the smaller one is the fibula. So the tibia is the primary concern of shin splints, and these red arrows here both show a little bit of a protrusion on the tibia, which is inflammation of the periosteum, which I talked about earlier, which would be diagnosed as shin splints and complaining of shin pain. So my research question is, can real-time biofeedback from wearable sensors actively modify an athlete's movement patterns to prevent overuse injuries, specifically medial tibial stress syndrome? So what exactly are wearable sensors? Wearable sensors are electronic devices designed to wear on the body to track, analyze, and to transmit personal data. I'm sure some of you guys are pretty aware and knowledgeable about Apple Watches or Fitbits, but some new technology like smart glasses or smart insoles. Smart insoles are going to be very important in a second. A lot of upper level elite athletes and programs are utilizing these to track training volume, to investigate better training patterns, and hopefully even prevent injury in the future. So that's my question. Can real-time biofeedback from wearable sensors actively modify an athlete's movement patterns to prevent shin splints? So for my study, I'm going to be conducting a 2-phase methodology. The first phase is going to be observational in nature, and the second one will be more interventional. For my participants in my study, I'm going to be taking 100 female collegiate athletes, 25 of which have never reported any shin pain before, 75 of which either have had shin splints in the past or are at risk of shin splints because of pain they're experiencing in their tibia. They're going to be in endurance-based and high-force sports, specifically running. In my case, it's going to be track and cross-country. My inclusion criteria include either a portion of my participants with no history of shin splints, as well as shin splints are at risk. My exclusion criteria is going to be males, people that have had previous surgeries or previous lower limb injuries, and any conditions affecting their gait, which is just their normal walking cycle. So for my first aim in my first phase of my study, it is going to be to characterize and investigate biomechanical and training load markers that correlate with medial tibial stress syndrome. My hypothesis is that athletes who are more likely to develop this condition will have elevated levels of specific biomechanical and training load markers in comparison to those who are not as likely to develop it. So my groups, for group 1, I'll have 25 females at high risk, and my second group will be 25 females at low risk. So you may be wondering, how am I going to figure out who is at high risk and who's at low risk? I'm going to be conducting 2 separate tests. The first test is going to be the navicular drop test, which is a test that assesses foot pronation. Foot pronation is a protective mechanism in place allowing for regulation and absorption of shock. So in the first picture here on the left, labeled A, is a picture of the patient. I'm going to have them be sitting down in a not weight-bearing position. This black dot here is going to be placed on the navicular tuberosity of the foot. The distance between the ground and that dot is going to be measured and marked with the line as a baseline. And then in the right picture, in B, you can see I will ask the patient to stand up on both feet in a weight-bearing position, which will be standing, and I will do the same thing, measure from the ground to that same dot. And if the distance between these two lines are above 10 millimeters, that is considered a positive navicular drop test, which also leads to and indicates excessive foot pronation, which is inward rotation of the foot when running, standing, any weight-bearing exercises. And that increases risk of shin splints, which would constitute as a high risk. And then the second test I will be doing is the longitudinal arch angle test. I will keep the dot on the navicular tuberosity. I will add a dot on the medial malleus, as well as the first metatarsal head, and then I will see what angle this is. A normal arch angle is between 150 and 170 degrees. A high arch is considered, there is an LAA less than 150 degrees, and flat feet are constituted when there is a degree greater than 170. Flat feet as well as extra arch feet are both at high risk for medial tibial stress syndrome due to improper muscle balances and weight bearing. So in my data collection, I'm going to be looking at tibial acceleration, ground reaction forces, foot striking patterns, step length, cadence, and joint angles. I'll be using attachable IMUs, which are inertial measurement units, force plates, and high-speed video to do this. I'll also be looking into weekly running volume and intensity of the training, different running surfaces and how that affects it, and overall step count as well. So what I'm expecting to see is I'm going to be able to identify which key biomechanical and workload markers are important and associated with shin splints. I'm hopefully going to discover a threshold of a specific number of which one of these biomechanical markers is excessive and which one is low, specifically tibial acceleration and ground reaction forcing. And then hopefully I will be able to put a relative weight of which one is the most important. Like I said earlier, there's way too many causes of shin splints, so picking out which one contributes the most to target that one in the future. So for my second aim, this is my interventional part. It is going to be to evaluate the effectiveness of real-time biofeedback and modifying the movement patterns and reducing risk of shin splints. For my hypothesis, it is to see key biomechanical risk factors associated with shin splints are going to be significantly reduced following the implementation of real-time biofeedback in these athletes. So for my groups, both of these groups are going to consist of 25 females at high risk for shin splints, except for my first group is going to be my control group, receiving no biofeedback, and my second group will be wearing smart insoles in their shoes, and they will be receiving real-time auditory and haptic feedback. Their auditory feedback is going to be a beep when their tibial acceleration is outside the limits of regular, and then their haptic one is going to be vibrations when their foot striking pattern is extra heel devoted or extra toe devoted. You want to be a mid-foot striker. So for my timeline, there's going to be 4 training sessions per week, 60-minute sessions each one. Obviously, it's going to be running based because that is what I'm looking into. And then I'm going to be monitoring their progress over a 6-week span. For my data collection, like I said earlier, group 1 is going to be equipped with regular insoles. That's going to be my placebo group. And then group 2 is going to be equipped with wearable technology, smart insoles. Okay, also key to note, my athletes are going to address any severity of shin pain before and after every single training session so I can compare these results later. So I'm expecting to see in my second aim, I'm going to expect to see improved biomechanical patterns, tibial acceleration that is decreased and improved in the foot striking pattern and lessened ground reaction forces. Secondly, I'm hoping to see reduced factors of shin splints. There's going to be a notable increase in ankle and foot mobility, lessened weight bearing imbalance, and increased step rates. And then finally, I'm hoping to see, even after I track these athletes for 6 weeks and I take away my biofeedback, this muscle memory has formed and corrections in their biomechanics of running should have been corrected a little bit, and it will maintain even after I take away the biofeedback. So to analyze my data, there's going to be 4 different ways I'm going to do this. The first one is going to be a correlation between the biomechanical and training load with the severity of shin splints. The second one is I'm going to take the mean and the standard deviation from these biomechanical and training load markers in group 1 and group 2. And then I'm going to compare the differences between these markers of high risk and low risk and see which ones are high, which ones are low. And then a logistic regression model will predict which predictors are the most important in developing shin splints. So for my future studies, I would love to expand on this study following the progress of these athletes over a longer period of time, even for a whole entire season, or maybe even a year or 2 seasons to see the difference. I would love to extend a study for male athletes and then compare between male athletes and female athletes. I would love to include other high force and high impact sports, volleyball, basketball, soccer, football, anything like that where you change direction a lot and there's a lot of running. Investigating the effectiveness of real-time biofeedback at different levels and divisions of competition, so maybe extending this to middle schoolers or high school athletes or even Olympic athletes and seeing the range of competition and if that has any effect on the training leading to shin splints. And then I would love to look into the physiological and behavioral impact of athletes following this real-time biofeedback. I'd like to acknowledge God for bringing me here, all my professors for all of your patience and your hard work with me, and then all of my friends and family, my teammates and coaches. I wouldn't be who I am or as successful without you guys. Here are my references. Any questions?
Chapel, does a person's weight have any correlation to shin splints?
Yes, it does. Body mass index is something that I sort of looked into, but not super in depth. I know that I talked a lot about ground reaction forces, and a typical ground reaction force just when walking is how much you weigh. But when you're running, it can be elevated to 2 to 3 times your body weight. So when your body weight is excessive, that's going to lead to even more stress.
Do you have a weight or BMI that you would like to consider in your studies, or no?
No, not really. I think I really just wanted to focus on females just because I'm a female and I know it's very prominent. I have a girl on my softball team who thought she had shin splints at first, led to compartment syndrome. And so I think it's very close to my heart, so I wanted to look into that.
And your college aged females, is there a certain age that you'd like to look at in particular?
Yeah.
Cut off at
Yeah, really just all college, like freshmen to seniors, just seeing like the range, because I could also compare like the extent of training, because obviously when you're a freshman, you're going to come in and not have a ton of like college experience and training. So that'd be cool to compare freshman year to senior year as well.
So I know you had seen biofeedback and they determine, like, I guess how their feet will touch the ground, see the sensors and everything. So what's the form of therapy that you're giving them to like improve or get better? Is it just like changing the way that they run?
Yes, so some like biomechanical corrections. So like I said earlier, foot striking pattern, if you're super toe dominant or super heel striking dominant when you're running, both of these are not super suggested in running. So correcting through biofeedback, my haptic.
So correcting form.
Yes, and like foot stride, length, stuff like that.
Just a fun fact, last night I read an article on this, which is just really wild, and they have a shoe that was designed to kind of collect data. Except the shoe had a button battery, and the button battery burned the feet of patients as they had distance running. So, should this progress into something, please don't use the button battery.
Great job, Chapel.
Okay, it's my pleasure to introduce the next speaker, Timothy Davis. Tim is majoring in biology with a concentration in medical sciences with a minor in chemistry. He's from Fredonia, New York, and has been at SU for 4 years. While at SU, he's served as the CNHS TA, SNTA Vice President, ACE Vice President, PHSO President, Side-Peer Mentor, Manager, Health Services Volunteer Coordinator, participated in both organic and neuroscience research, and served on a medical missions trip to Uganda. After graduation, he plans to attend Cedarville University in May to obtain his master's in physician assistant studies. Without any further ado, Tim.
Thank you, Dr. Senator, for the introduction. Once again, good morning, everyone. My name is Timothy Davis. I'm so excited and honored to talk to you all today. So when you think of plants, if you feed a plant, it's going to grow. For me, if I feed a plant, it's probably going to die. So if you feed a plant, it'll grow, hopefully. Feed a child, it'll grow. In the same way when it comes to cancer, if you feed cancer directly through energy, it's going to grow. So what my study looks at is cutting cancer's fuel line directly through dual lactate dehydrogenase A and monocarboxylate transport inhibition. So when we look around the world's cancer statistics, currently, every year there's about 20 million new cancer cases that are diagnosed every year. That's roughly 40.5% of the population, or 1 in 4 people that are going to be diagnosed with cancer. This equates to about 9.7 million deaths every year associated with cancer itself. Obviously, the second major cause of death. This is a major tolerant of what we're going to look at today. When we look at U.S. alone, currently the U.S. spends $208.9 billion on cancer treatment and expected to grow every year due to improvement in technological advancements. Current states such as New York, Pennsylvania, Michigan, Pennsylvania, Louisiana, and Florida have the highest diagnosis rate of cancer. And when we look at the difference between men and female, men are more likely to be diagnosed with cancer itself. And we look at the US and the world alone, the top 5 cancers include lung cancer, breast cancer, colorectal cancer, prostate, and melanoma. And for my study in particular, we'll be looking at breast cancer itself. So according to the World Health Organization, the American Cancer Society and the Center for Disease Control have very different definitions of what cancer is. So kind of give you a basic definition of what cancer is a disease in which abnormal cells divide out of control and invade other tissues. So typically this often occurs with symptoms first appearing. Oftentimes these symptoms aren't directly associated with cancer itself, they're indirectly. So the cancer itself is altering the environment in which they're present and allowing those symptoms to come up. From there, you're going to receive a diagnosis. Typically, cancers are diagnosed on a 1 to 4 stage. So 1 being the most localized form, or 4 is indicated that has metastasized. It's moved from one organ to a different organ, and often be the most challenging and severe to treat. From there, you get treatment options, as we'll discuss later on. Those treatment options will be implemented, and then from there, either you destroy the cancer and go into remission, or an alteration of cancer treatment itself. So we look at different varying cancer treatments itself. We have very different options. So hormonal therapy, we have surgery, we have potential bone marrow transplant, we have immunotherapy, radiation therapy, and obviously the most common one is known as chemotherapy. Oftentimes these are moved in tandem as a combination, is a more effective approach in treating cancer, often seen as a more aggressive combination. Typically you see radiation and chemotherapy put together. But for my study, we're going to look at chemotherapy, potentially 2 different kind of chemotherapeutic drugs itself. So if we can look at cancer itself, there's very different characteristics and features when it comes to cancers and how they operate in the body itself. So a couple of them include sustained proliferating signaling, evading growth suppressors, immortality, often called as they're going to replicate over and over and over again, activating invasion and metastasis, inducing angiogenesis. So for you, that angiogenesis is basically saying you're going to create more and more blood cells to bring more and more nutrients to the cancer cell itself. And then finally, we're going to resist cell death. However, in new research, as we're coming to find out, there are potentially new features of cancers that we're totally tapping into. One of those potentially being is that cancer cells itself are avoiding the immune system. So potentially recruiting tumor-associated macrophages that are used to protect the tumor itself and ultimately affect potentially cytotoxic T cells, macrophages, which are going to come in and destroy the cancer itself. A potential factor that's causing this to happen is an alteration in the tumor environment, the area around the tumor itself. We're seeing as a decrease in pH, and that's affecting the immune system itself. So one potential hypothesis or idea is associated with all of this in general is what comes down to is a major hallmark that's coming to a new light, which is dysregulated cellular energetics we're going to look at today. So cellular respiration is how your cells itself make energy in order to operate and function. So 2 different pathways. So we have an aerobic and an anaerobic. So aerobic is going to occur over oxidative conditions, and anaerobic is going to occur over the lack of oxygen. So we follow these blue arrows to give you an idea of what aerobic respiration looks like. Is glucose itself is going to enter the cell. It's going to go through this process called glycolysis, get converted to pyruvate. Pyruvate is going to enter the mitochondria, which I'm sure many of you heard of as the powerhouse of the cell. So from there, we're going to enter the citric acid cycle, and eventually go into the electron transport chain. We're going to produce ATP. ATP is what drives many of our functions of our cell. This is the energy currency of our cell itself. But as you can see, there's a multiple production of ATP. However, in the lack of oxygen, cells itself can go through this anaerobic respiration process, as seen through these green arrows. So same kind of similar fashion, we're going to go through glucose, go through glycolysis, and then from pyruvate, we're not going to enter the mitochondria. We're going to go through lactic acid production and produce lactate outside the cell. So what if cells itself are hijacking the system and making it beneficial for themselves? This will become seen as the Warburg effect. The Warburg was discovered by Otto Warburg in 1963, and he's now a hallmark of cancer itself, as we've seen. What's important about this, or different in cells compared to cancer cells, is that it's going through aerobic glycolysis. So as you've seen, anaerobic conditions are typically going from glucose to pyruvate and then eventually to lactate in the absence of oxygen. However, cancer cells itself are doing this process in the presence of oxygen. And so they're able to do this cycle over and over and over again. So from there, we're seeing an increase in glucose uptake. So from these cancer cells drawing in glucose and converting to lactate, glucose is going to go from a high concentration to a low concentration. So it's going to hold glucose more inside the cell. So typically normal cells are from 17 to 14% glucose uptake. You're seeing massive increase of 60 up to 70% uptake in glucose itself. From there, you're going to have this molecule called NADH that's depleted. So if you look here at the conversion of pyruvate to lactate, NADH is going to come in and get oxidized and get converted to NAD+. From there, typically, NADH goes into the mitochondria and feeds what we saw on the last slide, the electron transport chain, which produces the ATP. But from there, that NADH is being recycled into NADA and is not able to go into the mitochondria to complete ATP production. From there, since we're going to have this buildup of lactate in the cell, we've got to get rid of it somehow. Typically, cancer cells will pump this lactate out into the extracellular environment. From there, it's going to lower the pH of the microtumor environment, making it acidic. And from there, as we talked about earlier, due to the decrease in pH, you're going to have immunosuppression happen. It can affect your cytotoxic T cells, your T regulatory cells, and your macrophages itself. So when we look at everything together, what do you think is the main culprit? And what I found there is what if we can target lactate itself. So currently, when you look at lactate, here's the molecule of lactate. And according back to that pathway here, there's two main proteins I want to draw your attention to. The first being lactate dehydrogenase A. So lactate dehydrogenase A is going to convert that pyruvate into lactate itself. And our second is going to be monocarboxylate transport. That's going to shuttle the lactate from the intracellular environment over into the extracellular environment. Once again, leading to that immunosuppression and that decrease in pH. So what if there's a way that we can block both of these proteins and have an effect on cancer treatment? So currently, there are two different types of medications. Aloxane itself is still in clinical trials. It's not moved yet to humans. It's more focused in mouse models. However, serostinidine has been in human and is often used as anti-hypertension drug itself. So aloxane is an lactate dehydrogenase A inhibitor, and serostinidine is an monocarboxylate inhibitor. So what's great about these drugs, they have very similar properties. So they have an anti-cancer effect. They're going to dysregulate the metabolic function because they're going to block lactate and the production of lactate, which will hopefully remodel the microtumor environment and lead to immune enhancement. So what if we combine both aloxane and serostinidine as a more aggressive approach to cancer treatment to reduce cancer size and modulate the immune system? And that's exactly what my study looks at today. So two different parts. So my first part of my experiment is my evaluated synergistic or the combination beneficial effect of aloxane and serostinidine on cancer cell viability, proliferation, and apoptosis in an in vitro model. So my hypothesis is that there will be a decreased cell viability, proliferation with increased induction of apoptosis as compared to a normal breast epithelium. So when it comes to study, we're using three different cell lines. My first one is going to be an MDA-MD231, also known as a triple negative breast cancer. So these type of cancers lack receptors for estrogen, progesterone, and HER2. These type of cancers are more aggressive, and there's very limited therapeutic options for these. My second will be an SKBR3 or HER2 positive. So it does lack estrogen and progesterone receptors, but it does have that HER2 positive receptor. And these types of cells often have there's more therapeutic options in treating these cancers itself. And then lastly, using a normal breast epithelium known as an MCF10A to compare what standard cells look like under these conditions compared to cancer cells itself. For my control experimental groups, my control group will just be receiving DMS alone. This is the vehicle in which the drug is dissolved in. So you're going to receive those alone. We're also having a group that receives just aloxane alone, serostinidine alone, and a group that receives a combination of just aloxane and serostinidine together. For aloxane alone, there's different doses you can give. We'll be starting at a 30 millimolar concentration, and serostinidine will be at a 1 micromolar concentration. And then for the combination, we'll be taking both these individually and putting them together using DMS. So we come to look at and study cell viability, proliferation, and apoptosis. What will happen is we're going to administer the drugs to the cell lines themselves. We're going to measure them every 24 hours for early and late response for a total of 72 hours. From there, we're going to run two different tests to check for cell viability and apoptosis. So my first one's gonna be an ATP assay, and my second one's gonna be a Western blot. So by doing the ATP assay, we're going to check for ATP concentration. Since cells need ATP for continued cell viability, if they had a decrease in ATP concentration, we show that the viability has decreased and their functions have decreased as well. So what we hope to find is if we run these and stay numb through a slide, is a decrease in these number of green dots that pop on the screen. Confirming to us there's a decrease in ATP concentration. And then we run our Western blot, we're going to check for anti and pro-apoptotic markers. These are markers that are often associated with cell death or cell growth. So we run our Western blot, we're going to find these concentrations or bands of hoping to find high amounts of pro-apoptotic markers. So my expected results from this is we look at both my cell cancer lines, we're going to hopefully find a reduction in the ATP concentration. So we're not going to find many green dots on our screen. We're hopefully going to find an increase in BAX. BAX is a pro-apoptotic marker. We're going to hopefully find big, strong band on our Western blot, and from there we can infer that there's a decrease in cell viability, proliferation, and hopefully an induction into apoptosis. And then when we look at and compare that to our normal breast epithelium, we're hoping to find a steady state of ATP concentration, as these cells itself will be going through regular cellular respiration through normal mitochondrial functions. And then also the equal adaptions of BAX, which is a pro-apoptotic marker, and BCL2, which is an anti-pro-apoptotic marker. Both is going to inferring to us that these cells remain steady operating at physiological functions. This moves me into my second part of my experiment. My second part will be looking at determining the impact of dual inhibition on tumor-like metabolism and immune microenvironment during an in vivo study. So my hypothesis being there will be decreased tumor growth in correlation to altered cell metabolism and tumor microenvironment and linked to immune enhancement. So we're using two different mice models. My first mice model is going to look at lactate metabolism itself. This is going to be an MD231 xenograft model. So what's great about this model is that it lacks receptors for B cells, T cells, and cytokines, so we can look at just specifically how these drugs affect lactate metabolism itself without the alteration of the immune functioning. My second one is going to look at immunosuppression, which is a bulb C mice with 4T1. So 4T1 just being the breast cancer cell that's been injected into these bulb C mice. Bulb C mice are great for analyzing immune function itself. Very similar control and experimental groups. We have our control group, fluoxetine alone, serostimulin alone, and a combination of the drug itself. The only alteration being is the amount of drug being administered, since these are a larger specimen that we're dealing with. And then when it comes to measuring lactate metabolism and immune profiling, when it comes to measuring lactate metabolism through our xenograft model, we're going to administer the drug every 2 days, and we're going to image the mouses every 2 to 3 days for a total of 40 to 60 days. This allows us to analyze over long term, and we're going to analyze them through bioluminescence. And then we look at our bulb C mice to look at immune profiling. Same way, we're going to administer the drug every 2 days. However, we're going to image them every 7 to 10 days, still for a total of 40 to 60 days. And this is going to be using flow cytometry. So we look at lactate metabolism. This is kind of the idea of what bioluminescence looks like. So these high red concentrations are where there's rapid growth, high concentration of tumor cells, lactate metabolism happening, and those blue areas are more decreased concentration. So we're hoping to find over a correlation over 40 to 60 days is a decrease in these high red concentrations and more shift to these blue, and a decrease in the size of them themselves. So hopefully inferring to us that there's a reduction in tumor size and eventually an altered tumor microenvironment. And when we look at immune profiling, this is kind of ideal we did when you do cytotoxic or our flow cytometry looking at our cytotoxic T cells. Once again, our red area is a high concentration and our blue area is a more decreasing concentration. And so based on the presence or locations of these dots, refer to as the type of cells that are present. So we hope to find is an increase or more red prevalence where T cells and B cells will be located, and referring to us as a high increase in immune functioning, so there is enhanced immune function and a reduction in tumor size since these immune cells themselves are functioning. What I hope to look at in the future is to do a lactate assay to measure the potential lactate concentrations, because since we're inhibiting these molecules, want to find an effect if there's maybe production of lactate anywhere else happening, that we can inhibit those as well. Doing an next in VPI, so this is going to determine early or late apoptosis. So these drugs having an early effect or a later effect on the cancer cells themselves. And lastly, doing a liquid biopsy, where you're basically your standard blood draw to look at immunosuppression markers and see how these drugs are altering microenvironment of the tumor itself. I'd like to acknowledge God for allowing me to continue to study amazing creation every single day to learn more and more and more. My professors continue to challenge me and push me harder and harder to do better and to work harder. My friends and family for continued support, people to lean on and push me and encourage me. Here are my references, and if you have any questions, I love to take. Thank you.
Tim, if glucose is what's ultimately feeding the system, right,
Mhm.
and feeding the cancer cells, could you elaborate on the role of a diet high in added sugars in the proliferation of cancer cells?
Yes. So cancer cells, they're going to draw that glucose into them, so they're going to starve regular cells. So what we're hoping is if we can decrease kind of the glucose that's being converted, that glucose itself will go to regular cells and reduce kind of the tumor size itself. Is that kind of what you're
Kind of, but like if there's a diet that has an additional increase in added sugars, like
Mhm.
eating way too much, processed sugar,
Yeah.
how would that affect the cancer? And would a reduction in dietary sugar in combination with your drugs, would that potentially be more synergistic?
I think in general, a high sugar diet is probably not favorable because you're going to have other effects later on in life compared to just cancer itself. So just advise against that. But when it comes to looking at these models and glucose, and if you're having an increase in glucose itself, we potentially see these cells are going to increase more and more just because they're taking more and more glucose, because there's more glucose prevalent in the blood supply itself. So we can take more and more in. But hopefully, since this approach will be more dynamic or more aggressive, it can decrease the tumor size before it has grown to a more proliferative or unstable lethal state before it has later on effects. Yes.
I think it'd be cool for a future study to look at baseline serum glucose levels in like your 20s and 30s before you get into those high, fasting blood sugars, and see if there's correlation between, patients who are fasting in the 90s and that's just their standard, so they don't have diagnostic disease yet, but if they have more bioavailability of that, it may be, a predictor or something.
Yeah, a potential marker to any kind of cancer.
So thought-provoking.
Any other questions?
Okay, great job, Tim. Just take a second, and we're going to move to S107, which is the big room by the entry door for the alumni panel. So we've got the